Welcome to this video. My name is Dane. I hope you enjoyed our previous Active IQ video discussing the National Health Service structure and funding. The aim of this video is to help fitness professionals understand the NHS landscape and to discuss the opportunities and possibilities for us as exercise professionals. So in this video I'm going to discuss two key NHS documents, the NHS Long-Term Plan and the NHS Long-Term Workforce Plan. It's also worth noting that a new 10-year plan consultation is underway, so this landscape is constantly evolving and changes in government tend to accelerate this. So for those of you that missed the first video and are jumping straight into the second, my name is Dane Vishnubala. First and foremost, I'm a fitness professional, starting out in the fitness industry in 2002, initially working as a personal trainer, exercise referral instructor, amongst many other roles along the way. This included my first NHS role in 2004 as a healthcare assistant, before going on to York to study medicine in 2005. And following that, I now work as a consultant physician in sport and exercise medicine, a GP, and a variety of academic roles as well that you can see here. So I hope that my broad range of experience will help me navigate this interesting topic with you. So for nearly a decade, the NHS has been dealing with a significant slowdown in funding and growth in general. And while the demands of service and the cost of delivering it have gone up significantly, there's been cuts to public spend and social care funding, and so this has really driven up the pressures, which means the NHS performance has taken a significant hit. Waiting times are up and are constantly being missed, and finances of a variety of NHS providers are rapidly deteriorating. There are also workforce shortages that are widespread, so nearly 100,000 whole-time equivalent staff vacancies in hospitals, and this includes over 40,000 nurses. In June 2018, the Prime Minister announced a new 5-year funding settlement for the NHS. It promised a 3.4% average real terms annual increase in the NHS budget between 2019 to 2020 to 2023-2024. So this is nearly £20.5 billion increase in that period. But to unlock this, national NHS bodies were tasked with developing a long-term plan for the service. The resulting document, the NHS Long-Term Plan, was published on the 7th of January 2019. This settlement is a significant improvement on the funding growth the NHS has seen since 2009 to 10, which averaged about 1% in real terms. However, there's still an average increase. It's still well below the 3.7% a year that the NHS was founded upon originally, and less than the 4% that the King's Fund has argued is required to meet the rising demands of healthcare standards. The King's Fund dates back to 1897 and aims to inspire and catalyse improvements in healthcare by providing evidence and sharing ideas. Now, the NHS Long-Term Plan builds on the 2014 NHS 5-year forward view, which emphasised the need to integrate care to meet the needs of a changing population. Strategies cover general practice, cancer, mental health and maternity services. So see this as more evolution rather than revolution. Now, it's important to note that the funding settlement applies to NHS England's budget. So this means there's some important areas that aren't necessarily included here, and these include education and training. Local authorities, public health spending and social care are also excluded. So consequently, this is a plan for the NHS, not the whole healthcare system. And while it seeks to strengthen the NHS's contribution to things like prevention, population health and health inequalities, the plan's very clear that its progress depends on action elsewhere that also provide input into these areas. So compared to a number of countries, we are lucky that we live in a place where we have free healthcare at the point of access. Our healthcare service is reasonably well designed and at times, at points in time, was the envy of the world. And you are much less likely to receive unnecessary hospitalised care for a chronic condition here than in most other European countries. Now, NHS allocates funding based on population needs, and we've talked about this before in the previous video, and most of that care is provided through general practice. We plan our local and our specialist hospital services carefully around those, and our treatments and our management plans are generally all evidence-based, and that's what's approved through the NHS setting. But if we were to redesign the NHS now, there are a number of things that would be done differently, and that's what this plan tries to outline. And in terms of this outlining piece, we need to think about improving staffing and expanding the services that we currently have. But these aren't the only reasons there are pressures on the system. The other big piece that we need to have a look at is the prevention, and this long-standing goal to prevent as much illness as possible is a key part of this new plan. And where illness cannot be prevented, it needs to be ideally treated in the community and primary care where possible. If hospital care is needed, then the goal is to treat patients without having them stay as inpatients. Now, once patients no longer need to be in a hospital, they should get good health and social care support to go home, rather than take up beds, which is a constant challenge for us in the NHS. Despite improvements, the timing, location and manner of the care delivery itself can cause frustration, challenges and a waste of resource and missed opportunities, not just for patients, but for the healthcare teams. So imagine a paramedic who's frustrated because they can't answer the next 999 call because they're stuck waiting at the hospital to hand over a patient, and because the hospital's so busy that they're waiting with that patient. Imagine a young person who's come in with an asthma attack, but actually this could have been avoided had she had more time and resource spent showing how to use her inhalers correctly. Imagine a young person in mental health crisis who ends up in A&E because there is no good community or relevant community crisis team. Now, to improve patient care and reduce pressure on staff, this means the NHS needs to do a range of things. It needs to be more joined up and coordinate care. This means breaking down those kind of usual barriers between different organisations and teams that sometimes may not talk to each other, so that you feel like you have this one single point of access that connects everything together. The NHS needs to be more proactive in the service it provides. This might mean initial medical contacts when a patient calls the NHS. At the moment comes via 111 or 999 or a pharmacy visit or GP practice, A&E or urgent treatment centre. But at this point the NHS kicks in, but the problem has already occurred. So we need to find new opportunities and ways to prevent the problem, try and get an earlier diagnosis and stop this more reactive form of healthcare. And then finally, we need to look at more differentiated approaches to offering care to individuals. And this is really key to the NHS making further progress on the prevention front, but also reducing inequalities, which we'll talk about later, and responding to a diverse set of needs. So fundamentally, a one-size-fits-all is very hard to do, and we need to try and integrate and be proactive all at the same time. Now, these are big asks and a challenge for a system that has to be everything to everyone. The NHS long-term plan is all about focusing on preventing illness, and the list on the right here that you can see is some of the key focuses. And also looking at the left bar chart, you can see deprivation is another key issue. And we know that deprived communities, things like obesity, smoking, inactivity are all more prevalent. It recognises that keeping people healthy isn't just about what the NHS does. It depends on a range of actions, and this is individuals, companies, communities, and the government to tackle bigger kind of health threats and weave health into social and economic policies. The extra cost to the NHS due to socioeconomic inequalities are huge, and they're thought to be around 4.8 billion a year just from more hospitalisations. Now, the NHS efforts can complement but can't replace the crucial role of a local government. So local authorities handle planning, education, housing, social care and economic development. They also fund and commission preventive health services such as smoking cessation, drug and alcohol services, sexual health and early years support for children, including school nursing and health visitors. Now, these services are funded by central government through the public health grant, and their funding is constantly evolving and being decided. Given how closely these services work with the NHS, these effective services have big knock-on impacts. And there is a conversation about whether the NHS will look into whether the NHS should play a bigger role in commissioning sexual health services, health visitors and school nurses, and figuring out the best way for all of these different groups to work together. Now, the Global Burden of Disease study highlights the top risk factors causing early death in England. And these are smoking, poor diet, high blood pressure, obesity and alcohol and drug use. Now, air pollution and lack of exercise are also big issues. Now, these priorities are all focused in the NHS prevention programme. As mentioned in the previous session, the new integrated care systems, which we talked about at length, will help deliver these programmes as the NHS shifts from reactive care to a model of active population health management. So the integrated care systems, or ICSs, will provide stronger foundations to work with local government, voluntary sectors, and on the broader agenda of prevention of health inequalities. Now, the aim is they'll be supported by these expanded teams across groups of neighbouring GPs working together under a primary care contract. The NHS also hopes to play a role in secondary prevention by detecting disease early and therefore preventing deterioration. So remember, primary is when you stop the disease occurring, secondary is when you stop the disease getting worse. And every day we know the NHS interacts with about 1 million people, highlighting the real driver around personal impact of ill health. Now, the long-term plan sets out practical actions to use these interactions as opportunities to help people improve their health. Now, this will contribute to the government's goal, really, of adding 5 extra years of healthy life expectancy by 2035. Now, the NHS long-term plan not only helps to treat people, but also prevent them from getting ill in the first place, as we talked about. And this is critically important, and we'll come back to some of these key risk factors as we go through in more detail. But ultimately, to probably summarise, the plan aims to ensure everyone who stays overnight in hospital gets help to stop smoking if relevant, face-to-face support in pregnancy for women to try and stop smoking, help people using outpatient services for conditions worsened by smoking, such as cancer, to quit smoking, ensure people can access support to manage their diabetes, ensure people can attend weight management services, ensure people admitted with alcohol-related problems have care from a specialist alcohol care team. To continue to use antibiotics sensibly so they remain effective for future generations, and this is the concern around antibiotic resistance, so we need to prevent that from happening by not throwing antibiotics at everything but only at things that need it, and then providing a range of digital tools like smartphone apps to enable more people to access NHS services. All of these things we hope will help with prevention, but also potentially some of the health inequalities we were talking about. Health inequalities are basically about the differences in people's health, but it also covers the differences in the care people get and the chances they have to live healthy lives, both of which can affect their health. So health inequalities can mean differences in things like people's health status, so how long do they actually live, access to their care, so what services can they access, quality and experience of care, so how satisfied are patients, behavioural risks to health, so things like do they smoke, and then wider determinants of health. So these are things like, for example, their quality of housing. And when we look for characteristics for this difference, this could be a range of things. This could be deprivation, could be socioeconomic status, it could be their sex, it could be their ethnicity, it could be their sexual orientation. But whatever it is, we want there to ideally not be any health inequalities and people to have the same types of health status, same access to care, and be satisfied with the care they get. For example, a healthy life expectancy is nearly 18 years lower for those who are most deprived compared with those who are least deprived. And that's really concerning statistic, to say the least, and something that I think everyone, and particularly the NHS long-term plan, is really emphasising trying to tackle. Over the past decade, the quality of care and patient outcomes for major conditions has really improved. Childbirth is safer than ever. You've got cancer survival rates at an all-time high, and deaths from cardiovascular disease have halved since 1990. and male suicide rates are at a 31-year low. But there is still significant evidence that the NHS can do better, and there is a lot of variety in the service quality between different clinical teams in different regions, and there are lots of unmet needs in the mental health service, and particularly through things like significant waiting times in order to access it. Now, the NHS long-term plan lays out clear and costed priorities for tackling the biggest health challenges we face, and that's the kind of aim. Now, the priorities are based on the latest evidence from the Global Burden of Disease study for England, which again we'll talk about shortly. And it emphasises key areas like cancer, mental health, multimorbidity, so many conditions, and healthy ageing. And it highlights the importance of focusing on children's health, cardiovascular and respiratory conditions, learning disabilities and autism. The plan also recognised the value of therapies and planned surgery for conditions that affect independence and quality of life. Now, the goals of the plan, some are set at 10-year targets because it takes a lot of time to expand capacity and grow a relevant workforce. So, for example, by 2028, the plan aims to significantly improve cancer survival rates by increasing the proportion of early diagnosis by 50%, from 50% to 75%, so a significant increase. There are other goals that might be achieved sooner. So, for example, the aim is to halve maternity-related deaths by 2025. But you can see this gives you an idea of the aspirations here. However, this comes at a significant challenge and does take time. So the Global Burden of Disease study was published in the Lancet, and we've talked about this already or signpost you to it. And it outlines the estimated years of life lost, so YLL, or years lived with disability, YLD, or disability adjusted life years, DALYs or DALYs, and attributor risks. And this study looked at data from 1990 to 2016. Now, we'll signpost you to the actual paper itself if you're interested in having a read, but here is an extract from that study, and this is the table that was shown here. Now, looking at this table from this study, you can see that the population attributable fraction for risk factors is shown here for each of the home countries. Now, the population attributable fraction is the proportion reduction in population disease or mortality, and this will occur if the exposure to that risk factor is reduced to an alternative ideal exposure scenario. So, for example, you have tobacco or smoking at the top. That would be in comparison to non-smoking, for example. And you can see that things in green are behavioural things in blue are environmental things, and things in red are metabolic things. So you can see that the path, so reduction of smoking, if stopped, is 19%. That's significant. You can see dietary risks play a significant part to risk factors for health. We've got blood pressure there, being overweight, alcohol, drug misuse, total cholesterol. You can see some occupational risks there, high fasting plasma glucose, so kind of that hint towards diabetes, air pollution, and then finally low physical activity, which is still there in the top 10, so it is important. And interestingly, physical inactivity can affect the others. So being more active, statistically, you're less likely to smoke as much. Being more active, your blood pressure could reduce significantly, and we're talking about up to 7 millimeters of mercury, so a significant amount. We know that being more active will increase your HDL, so therefore improve your cholesterol profile. We know that being more physically active will make you more insulin sensitive and therefore hopefully reduce your fasting plasma glucoses. So all of these things can be influenced by physical inactivity. So while it's top 10 there, it has a wide-reaching set of exposures as well to consider. The NHS long-term plan lays out a range of actions to improve how we detect and care for people with cardiovascular disease and respiratory disease, to prevent diabetes, but also stroke services. Now, all of these are wrapped up in cardiovascular disease. Now, the goal is to prevent up to 150,000 cases of heart attacks, strokes, and dementia in the next 10 years. In terms of cardiovascular disease, This is the cause of 1 in 4 deaths in England and is the major cause of illness, disability, and health inequalities. Now, the risk factors of cardiovascular disease also apply to other major conditions, so things like cancers, dementias, and diabetes all share similar risk factors. So preventing and managing cardiovascular disease is important to overall health, not just CV health, reducing health inequalities, but also ultimately if we're trying to reduce the pressure or burden on our NHS services. Integrated care systems can tackle cardiovascular disease through partnerships and leadership, and public health focused on prevention and management. It can do that through education and raising awareness, using data and technology effectively to monitor, evaluate and action, and also to ensure that there's a reduction in clinical variation. So wherever you go, you get a similar level of care. Now, this work is informed by the analysis of published data on cardiovascular disease, which is fairly significant, and we know this is a significant problem for us. It's the single biggest condition where the NHS can save lives over the next 10 years. And as we said before, it is the cause of 1/4 of all deaths in the UK. Now, there's a range of ways we can try and improve cardiovascular disease. This could be through NHS health checks, working with community groups, through looking at how we improve technology, but also improving survival during cardiac arrest. So the plan kind of focuses on each of these in turn. The plan wants to improve the effectiveness of NHS health checks to identify those at high risk of cardiovascular disease, or have it, through things like either atrial fibrillation, high blood pressure, high cholesterol. It wants to support people with heart failure and heart valve disease through getting them tested early in primary care and working with multidisciplinary teams as part of that wider primary care network that we talked about before. It wants to provide opportunities for the public to check on their own health. We want to increase access to cardiac rehabilitation to ensure a program of exercise and education for those who've had heart attacks. So again, this is core fitness industry settings. So again, something we should really be trying to influence. We need to be working with partners to improve community first response, building a defibrillator network. So essentially we want to improve the survival if you have a cardiac arrest outside of the hospital. And finally, want to improve access to things like genetic testing for familial hypercholesterolemia. And by hopefully making an earlier diagnosis and treating this, we can reduce the risk of sudden cardiac deaths. The NHS long-term plan is making a big push to improve and widen access to mental health, both not just for adults, but also for children. The plan highlights and outlines possibly one of the fastest expansions in mental health services in NHS history, with the aim that thousands more adults will be able to access talking therapies for common disorders and to provide better support for children and young people. It aims to improve how the NHS treats people with severe mental illnesses, particularly during crises, but also to support mothers experiencing severe mental health issues to get the treatment they need. The plan has a range of aims, and in terms of the outline, I would say the key highlights are this transformation of mental health care, so more people can get the treatment they need, requires an increase in funding. So we're talking at least 2.3 billion a year by 2023-2024, so much bigger budget. Making it easier and quicker for people of all ages to get mental health crisis care, so kind of all-round 24/7 care, including through NHS 111. Expand specialist mental health care for mothers during and after pregnancy, offering mental health assessments so that support can be directed earlier. Expand services through schools and colleges, so an extra 345,000 children and young people between the ages of 0 and 25 can get the support they need. Continue to develop community and hospital services, particularly talking therapies that have long waiting lists. But I think the most important thing this gets across is this plan is a political statement affirming support for mental health services and the recognition that this is a problem that needs more funding, more support and more growth, really. So as we've said, this will grow faster than total NHS spending, and we've talked about that kind of 2.3 billion higher spend in real terms. The maternity and neonatal section of the NHS long-term plan builds on the measures from the National Maternity Review. Now, the goal is to halve stillbirths, maternal mortality, neonatal mortality, and serious injuries, brain injuries in newborns. And the commitment is to improving continuity of care during pregnancy, birth and afterbirth, increasing the bed capacities in intensive neonatal care where it's needed, and boosting mental health services and other support for pregnant women and new mothers. By wrapping care around the mother and the family, the NHS is hoping to give every child that kind of best start in life from birth to adulthood. So there's this real push around this from cradle to the grave piece. Now, over the next decade, the NHS long-term plan will keep trying to improve maternity care and services, but also for children through long-term conditions like asthma, epilepsy and diabetes. The aim is to make maternity services safer, offering women more choice and providing more specialist input to mothers at risk of premature birth. This will include stop smoking as well. So the Children and Young People's Transformation Programme also aims to improve mental health, learning disabilities and cancer services to ensure there's a joined up approach for children and young people. So the whole plan aims to make sure that we can halve the number of stillbirths, mother and child deaths and serious brain injuries. It aims to ensure that most women can have the same midwives, so that continuity of care throughout their pregnancy and beyond, increase the amount of support that women and men experience in terms of mental health during and after pregnancy, and essentially we're talking about the family as a whole here, reduce any visits from children by improving children's health services. And the aim, I guess, is to treat an additional 1,000 children per year for severe complications related to obesity, such as diabetes, cardiovascular conditions, sleep apnea and poor mental health. But as we said before, prevention is a big driver here too. In terms of cancer, cancer has been a significant priority, and we know that more people are surviving cancer than ever before. And we know that we can save even more lives if we catch cancer early and start treatment early. Nearly 1 in 2 people in this country will be told they have cancer at some point in their lives. Our NHS long-term plan aims to save thousands of lives. And this long-term plan aims to do this by increasing dramatically how we diagnose and treat cancer. The aims by 2028 to have an extra 55,000 people each year survive for 5 years or more after their cancer diagnosis. So this includes improving our screening programs, having fast access to diagnostic tests, investing in cutting-edge treatments and technologies, and making sure more patients can quickly benefit from precise, highly personalised treatments as medical science advances go. So to do this, the plan is going to lower the age of bowel screening, introduce new forms of cervical cancer screening, potentially extend lung health checks to try and pick up cancers earlier. And to do this, we might need to create rapid diagnostic centres, so it could be assessed in one day, introduce faster diagnosis standards, such as trying to rule out cancer within 28 days of a concern, and try to build personalised packages for those with cancer. And of course, we want to make sure people have access to effective tests and treatments, whatever that is. And as technology changes, keep up to date with that technology. Now, on the right there, you can see some of the NHS screening programmes. And while they don't just include cancer, you can see that bowel, breast and cervical are our big cancer screening programmes from that image there. So people in England are living longer than ever before. If you look back to 1841, males average approximately 40 years, while females 42 years. Now males would average nearly 80 years and females average 83. But these extra years aren't always fully spent in good health, with a quarter of the UK population living with a long-term condition. Now, many folks develop conditions that reduce their independence and their quality of life and puts a big pressure on the NHS. And arguably, the NHS has a key role in supporting people with long-term conditions and making sure they've got the right support to live as well as possible. So the NHS long-term plan outlines kind of the main aims, which is really to give control to these individuals with long-term conditions over their care, being able to provide support closer to home rather than always in hospitals, and to make better use of technology like wearable technologies and monitors to allow people to live independently for longer. So the aims really are of Aging Well is to promote a multidisciplinary approach with a range of healthcare professionals tailored to help the individual live independently for longer, give people more say in their care, offer more support for people who look after family members, partners or friends, develop community rapid response teams to help manage issues and keep older people out of hospital, offer more NHS support and care homes as well. And you'll see there is an updated document called the Framework for Enhanced Health and Care Homes, which may be worth a review if you're interested. Now, this image is an image from Skelton and has also been used in the Chief Medical Officer's physical activity guidelines. And what we're trying to get across here really is that maintaining muscle strength is important for independence and contributes to a longer and healthier life. So we know from a range of studies that stronger muscles can significantly enhance health and lifespan, with one study showing that muscle mass can reduce the risk of death from all causes by 40%. Now, if you look at the graph there, you can see that of the two lines, the line at the top, so the black line, represents those who stay active with strength and balance exercise throughout their lives, while the line at the bottom, the purple line, shows those who don't. The black line here stays high and indicates better health and independence. And I guess that inability to fall into that disability threshold where you might need care or support. So for us, this is critical, and probably some of the key points to get across is physical activity throughout life with a focus on bone strengthening, balance and muscle strength are key. We need to start this early, and we need to continue it throughout the life course in order to prevent a decline. And we talk about muscle building, there's this constant conversation around muscle turnover increases as we get older, particularly mid-30s onwards, so therefore muscle mass starts to decline. And while this is true physiologically, that doesn't mean muscle mass needs to decline, it just requires more stimulation to maintain it. And there are a range of studies supporting this, showing that actually exercise can counteract this decline in function. Most research focuses on muscle loss in sedentary older adults, raising the question of whether muscle aging is due to aging itself or is it actually just lack of use. And one particular study looked at regular intense exercise and showed that it could prevent muscle loss and strength decline in inactive older adults. And it used 40 high-level recreational athletes aged between 40 to 81 who trained 4 to 5 times a week to prove this point. Now, some of the biggest issues the health service is facing right now is workforce shortages, and the NHS long-term plan recognises this and takes some steps towards trying to tackle it. However, we will be talking about the workforce plan, which is the more newer document in due course. But to help improve the workforce staffing issues, there are a couple of aims made. One was to try and cut nursing vacancy rates from 11.6% to 5% by 2028, to increase the number of placements for nursing graduates, to make nursing more accessible through a range of new pathways, including online nursing degrees with guaranteed clinical placements and apprenticeships. There's a concept of the new nursing associates that has started from 2019. There's an aim to increase medical school numbers from 6,000 to 7,500. And there's a shift to move a range of clinicians from specialised roles back into generalist roles, because it feels like that serves patients with multiple long-term conditions better. And then finally, to support general practice further and widen that primary care team. So this might include clinical pharmacists and physiotherapists to help bolster numbers and improve support. Now, of course, controversially, these have their challenges when you move away from the more traditional models used around the world, and we'll talk about this in due course. In terms of digital technology, the aim of the long-term plan is to try and shake up digitally as well. The aim is to focus on a range of things that might provide benefit to patients. So think about the NHS app. The aim was that this would be the go-to for patients accessing services and information, checking their care plans, and potentially even talking to healthcare professionals. The aim of a digital primary care is that you'll have the right to access digital primary care services like online consultations through this kind of approach of a digital first. Of course, there is a place and a time for an online consultation versus when you need to see a human being. And sometimes this digital approach might just be to triage, see the patient, make a decision about actually, do you need to come in or can I manage you remotely? And this is the big shift in how healthcare professionals are being trained as well. I think COVID has accelerated this significantly. The aim is to fully digitise as well, so all secondary care providers, so hospitals and onwards, to move towards being fully digitised. This means electronic record systems and other capabilities where actually some hospitals are still on paper. The other thing is to really piggyback innovation technology, so everything from medical breakthroughs to digital services to app rollouts. We now have electronic prescription services that are now used by 93% of GP practice, and they actually save the NHS 136 million every 3 years. We've got e-referrals again to stop faxing and posting, and this service again allows online direct booking through a mixture of staff saving but also time saving and other physical costs. There's a 50 million saving a year here, and there's more and more examples of this saving approach. So the aim is to continue to disrupt, to use a digital first approach to try and save money, align and make resource use more efficient. So if we look at how the NHS uses taxpayer money, this is really important, and one of the other aims is to make sure that it's being used effectively. The first thing to say is that in 2018 there was an announcement of a growth in NHS funding by 3.4% each year of the next 5 years, and we talked about this being an extra 20.5 billion in money. So the first thing is a recognition that more money was needed. But with people living longer, particularly those over the age of 85, the NHS needs to support more people with multi-morbidity or greater health needs or more conditions. And the costs with ageing are that they cost more, and this is rising faster than ever before. So there's a big push to balance the finances in the NHS and incentivise and encourage that. There's a push to be more productive, and there's a target around a 1.1% productivity growth each year, and that's saving to then go back into frontline care. To focus on integrating services and prevention, because that should have a knock-on effect saving money. To reduce variation, so wherever you go that you get a similar style and approach to healthcare, and that wherever you are in the country that you get a similar approach. And that's important if we want to try and gain consistent care for anything. So let's take cardiovascular disease. If you've got a postcode lottery going on, then the overall care and quality won't be the same UK wide. So we need to try and understand what those gaps are, what those inequalities are, and try and reduce that variation. So finally, the last section we're going to talk about is the NHS long-term workforce plan. And this really complements the initial NHS long-term plan. And this plan can be broken down to train, retain and reform. The NHS workforce plan aims to ensure the NHS has the workforce needed for the future. So here's a kind of breakdown of what the NHS plan is trying to do in this area. So the aim is to double medical school numbers from up to 15,000 a year by 2031. The aim is to upgrade GP training numbers by 50% to 6,000 by 2031. The aim is to boost nursing training numbers by 92%, so a significant amount, to nearly 38,000 by 2031. The aim is to also have apprenticeships running for nursing and to increase clinical staff training through apprenticeships by 22% by 2031. The approach is also to start medical degree apprenticeships, so doctors by apprenticeship, with pilots starting shortly and aiming to get 2,000 students through this by 2031. Again, this is seen as rather controversial. Dentistry training to expand numbers by over 40% to over 1,100 by 2031, and to really try and push our domestic training so we're not reliant on international recruitment as well. The other challenge for us is to retain staff. There's no point just training staff, can't retain them, and many people are leaving the NHS because of the cultural issues, the challenges, the pressure, and the other options available to them. So working on culture, leadership and well-being are key to that. And this has been done through the NHS People Plan, trying to promote flexible working, health and well-being support, retirement flexibility so that people can continue to work in their retirement without affecting their pensions. Emeritus Doctor Scheme, which allows retired doctors to support some of the outpatient care. Professional developments, so funding for nurses, midwives and allied healthcare professionals. Dentist retention through working out how to encourage new dentists to spend time delivering NHS care rather than going privately. Trying to work out how to do childcare support to keep healthcare professionals working who may otherwise be looking to stop or reduce hours due to their childcare demands. There's a range of challenges here, but the other key and controversial point is the addition of new roles such as nursing associates and physician associates. Physician associates, for example, are 2-year degrees. They are master's degrees done by people with a prior degree in something else, usually science, but doesn't have to be. And the government is looking to increase these numbers, as well as nursing associate numbers. However, these have had pushbacks from the doctors' unions, who feel that doctors are being replaced by physician associates. So while these numbers are here, the British Medical Association, the Royal College of GPs have all said that there is no place for physician associates in primary care, and there's controversy over their roles in secondary care and other places. So watch this space. It's hard to comment further, and I'll try not to bias my own political opinion here, so I'll move on from there. Okay. So the training of doctors is an interesting thing to talk through. Now, the training of doctors generally starts with 5 years of medical school, which could have a degree before it or not. Following graduation from medical school, following a set of exams, you apply for foundation training. You could be put anywhere in the country and you might do 2 years of rotational training. So I worked in Scarborough and Hull, moving through general medicine and surgery jobs. So you work under a specialist or a consultant, so you're supervised to some extent and you carry out NHS services. Following this, you earn a completion of portfolios and potentially relevant entrance exams. You can then apply for training. So for sports medicine, for me, I could have chosen internal medicine training, general practice training, or acute common stare, so A&E type training. I chose general practice training and I did that for 3 years. If you wanted to be a cardiologist, you'd choose something like internal medicine training at the top, and then you'd apply for cardiology training where you see the green box instead of sports medicine training. So I did 18 months of hospital training. So that was a mixture of A&E, general medicine and ear, nose and throat max fax training. And then I moved into 18 months of GP medicine along with out of hours GP urgent treatment centre type placements as well. Following a couple more exams and portfolios, I then got my completion of training, which I could have worked as a GP and stopped there. Or if I wanted to be a cardiologist and I did internal medicine, or if I wanted to do sports medicine, I'd now apply to what's called ST3 training. And for me, I applied for that in sports medicine. There were 8 or 9 numbers in the country that year. So fairly competitive to get in. And then if you get in, there was another 4 years of rotational NHS training. So for me, I did rotations in A&E, orthopedics, rheumatology, radiology, musculoskeletal services, sport, cardiology, respiratory, exercise testing, amongst others, including public health as well. So really broad base of training to get my specialist recognition or completion of training, or CCT, in sport and exercise medicine. So you can see that it's a very long journey. So for me, for sports medicine alone, it's 14 years, and actually cardiology or orthopedics might be a year or two higher. So these are long training programs. And you can see the government, from previous comments, is trying to make training more efficient. And some of this is to save money, also get more healthcare professionals into the service earlier. However, trying to do this means shortening training or removing things. And there is significant concern over the implications this on patient care and the quality of the training of doctors on the other side. So there's a lot of resistance from particularly the doctors' medical associations to ensure there is no reducing of quality of standards of doctor or the replacement of doctor by other healthcare professionals that have not had the same rigorous training as well. And so again, clearly a very political move, and a lot of political debate to be had here. In terms of training of nurses, again, a bit like doctors and physician associates and that push and pull currently going on. Nurses have nursing associates that have also formed, and the aim is to free up nurses to do the more complex tasks while leaving the associates to do the more straightforward tasks. And a bit like physician associates and doctors, the scope and definition of scope and defining it and making sure people work within that training is critical. And of course, over time comes scope creep. So for the physicians anyway, and physician associates, the doctors groups, and particularly the unions, have almost called out and said there is no role for a physician associate in the NHS. And actually, this is more about the government supporting and encouraging doctor numbers to ensure adequate patient care, and doctors are concerned about patient safety. There's been some similar noise in the nursing fields, however, possibly not as strongly. But again, there are nurses and nurses associates. Now, a nurse has a 3-year degree, and usually they then work as either a child or an adult nurse or in mental health. But they can specialise further, and there are mainly exceptional nurses working in primary care and secondary care doing advanced roles. I work and have worked with many in primary care, and these tend to be nurses or advanced care practitioners with significant years of experience before subspecialising. And so to clarify and explain, this is very different to associate roles where there are quick and short degrees. These nurses have generally had decades of clinical practice and work before specialising, and is a tried and tested model that has been used in the NHS for decades and decades. A physiotherapist can be a 3-year undergraduate degree or a 2-year master's for following another degree. And again, physiotherapists, like nurses, can subspecialise post-graduation. They can move into banded roles, normally starting at band 5 and working themselves up. So these are pay scale bands, and nurses, physios and allied health professionals are all part of the agenda for change banding. But as a physio becomes more senior, a nurse becomes more senior, that number goes up. So you can go up to band 8s. But these tend to be more leadership and strategic positions. But again, physios and nurses can learn to prescribe and give medications. They can do a range of roles that historically may have traditionally been done by a doctor. But again, these are healthcare professionals by background, usually with significant experience. So again, very different to when it's done by an associate type role. So the train section of the program and plan really tries to get across that commitment that there needs to be a 50 to 65% increase in domestic education across a range of staffing groups. And this is to stop the reliance that we currently have on international recruitment, and also on the use of temporary staffing, which is expensive, and the workforce gap. So we've talked about how we're going to train and increase numbers across medical schools, GP training, through medical degree apprenticeships. That is potentially slightly controversial. There's a current conversation around shorter medical degrees, reducing them from 5 years to 4 years. And while this might be possible by just removing holidays alone and tweaking a few bits, there's still concern about reducing or removing from the curriculum. There's an increase in adult nursing training numbers by significant numbers, as well as mental health and disability nursing. There's a push to increase apprenticeships, particularly nursing, by nearly 20%, whereas now it's closer to 10% through apprenticeships. The aim is to push midwives through apprenticeship model, aiming for a 5% annual uptake alongside their normal traditional models. The aim really now is to support people to increase their skills, so increasing the number of independent prescribers through pharmacists as well, increasing the number of dentistry places, amongst many other things. But you can see the big push here is trying to train our own in-house and stop being so reliant externally. The plan highlights that without a better culture and improved staff retention, the shortages in the NHS are going to continue. There's well-known fact that NHS staff experience burnout, and significant numbers of NHS staff are leaving. So if we don't want that brain drain, not only from the NHS, but actually what's also happening is that we are getting lots of our skilled workers leaving to other countries. We need to change our culture, improve it, and therefore hopefully improve staff retention. So the Department of Health and Social Care is trying to introduce reforms to allow staff to partially retire and return to work more seamlessly. They're trying to encourage workforce to stay working for longer. They're trying to improve the culture in general through improving childcare support for NHS staff, amongst many other things. But what I thought I'd do is share with you something called Hesberg's motivation hygiene theory, and to start to get you thinking about what that looks like. So this theory is a two-factor theory and explains what drives job satisfaction and dissatisfaction. So there are two sets of factors. They're either motivators or hygiene factors. So motivators at the tops in green are the things that make people happy with a job and are related to work themselves. They can be achievements, so completing tasks, seeing good results. So having a job where you can see a sense of achievement, where you get recognition or praise and are rewarded for good work, where you find your job interesting and engaging, where you've got some responsibility or autonomy over your work and your decisions, where you've got the ability to advance, progress and promote, and therefore see a career growth, where you can see personal growth and professional growth. Now, these are important. These are the motivators that make people happy, whereas hygiene factors just stop people feeling dissatisfied. They don't necessarily make people feel happy. So hygiene factors are things we need to make sure are in place. These are clear and fair policies or company policies, high quality supervision and management, fair pay and adequate pay, providing good environments where there are good relationships between colleagues and supervisors, ensuring safe and comfortable work, and of course making sure that jobs are stable and secure. Now, all of these things will help us to retain staff. In terms of the reform section of the plan, this is about working differently to boost productivity. This means building teams with flexible skills, changing the education, changing the training to get more staff into the right roles to make sure everyone has the skills they need. Now, the plan focuses on expanding enhanced, advanced and associate roles to modernise careers, and it emphasises generalist and core skills needed for patients with multiple conditions. Over 6,300 clinicians started advanced practice pathways each year. So these are these advanced roles where clinicians got additional skills. We know that nursing associates, the plan is to build the workforce by 64,000 by 2036. Again, this is currently being discussed and debated by nursing groups. We know that physician associates, the plan is to establish a workforce of 10,000 by 2036. But again, there is a lot of political pushback by medical unions and doctor groups. We know that there's a push to adopt more AI innovations, and the challenge with AI is that balance between security and trust, but it has great potential to help with efficiencies. There's approaches to changing the way we do medical education, such as moving from larger programs to shorter programs, and particularly for doctors, there's a push towards a 4-year program. So we will see how these pilots roll out, but also interestingly, what its effect is on how other countries recognise our medical education system, given we are now going to a much shorter model than is common in many. And then finally, the aim is to try and address geographical inequity. So this is things like where training posts are around the country, given that we know that more deprived or lower socioeconomic areas can struggle to attract and retain staff. So how do we promote staff to these disadvantaged areas? Finally, as part of healthcare revolution, there are other things going on the side, and one of them is we know from numerous studies that healthcare professionals do not feel confident around physical activity, and we know it's a key driver or key important part of this prevention agenda. We know that many GPs are not familiar with the national guidance for physical activity, and the same with physiotherapists and in fact nurses. We know that undergraduate curriculums do not teach preventative medicine, let alone physical activity, which is key to many health condition managements. So there's been a programme of education to try and plug this gap. So this has been a partnership between what was originally Public Health England and Sport England. This programme has now moved to a consortium run by the Advanced Wellbeing Research Centre in Sheffield and the Faculty of Sport and Exercise Medicine and Intelligent Health. So if you are interested, have a look at the Physical Activity Clinical Champions Programme, and you can find this if you search online, and also the Moving Healthcare Professionals Programme as well. And again, this programme has made a significant impact in educating healthcare professionals around physical inactivity over the last 10 years and is continuing to improve its model, but also as well as having champions, so educators that are healthcare professionals dotted around nationally providing education to large groups of other healthcare professionals, it is also starting to embed itself in places, so having more champions and educators locally based inside their areas of employment to really influence change at the ground as well. So again, have a look at this space if you're interested. But again, there's a big push NHS-wise to ensure healthcare professionals are aware of physical activity. But at the end of the day, it needs to be someone on the other side to actually provide and do the doing. And I think this is where some of our fitness industry work can come in. So in terms of what is the Physical Activity Clinical Champions or the Moving Healthcare Professionals Programme, this started back in 2014. It was a government rolled out national physical activity framework called Everybody Active Every Day. So if you haven't read, that's definitely a good starting point, and you can find that online. And this framework highlighted how crucial healthcare professionals were to get people more active. And this led to the creation of this Moving Healthcare Professionals Programme. And this programme, as we said before, was initially led by Sport England and Public Health England, and has now been taken over by the consortium. It provides free training and resources by healthcare professionals for healthcare professionals on physical activity. It's moving to doing a place-based approach, so providing healthcare professionals and educators locally to try and influence people in their own communities. And it continues to grow on its programme and work with a range of other partners. So if you are interested, I think this is a really good way to slot in and see how the physical activity space engages with the NHS. Finally, as part of signposting, Moving Medicine is run by the Faculty of Sport and Exercise Medicine with a range of funding streams that support it. And it provides resources to help healthcare professionals promote physical activity to their patients who have long-term conditions. It's evidence-based, and it has a range of other courses, including how to change behaviour called Active Conversations. But it also has a range of toolkits for those interested in integrating physical activity into their primary care and hospital settings. So again, do have a look at this. It might inspire you and help you get involved in things happening locally at community level. There are a range of resources you might find helpful as we close off these two documents that are physical activity related in the NHS. There is the Royal College of GPs has e-learning that its GPs can have access to around physical activity, but of particular importance for you, there's the e-learning for health website, which actually you can sign up to for free. There's a moving medicine website, which has a range of resources to provide healthcare professionals with advice with 1 minute or more minutes around physical activity, which is really important. The Royal College of GPs has a whole active practice set of resources and toolkits aimed around promoting physical activity. So there's a range of resources here for you to have a look at, peruse, and decide how you best fit into this. It's important to highlight there are a range of global, national and local level policies that all support physical activity. So here are some of them that you may want to read. There are some newer policies, so things like advancing our health prevention in the 2020s, the gear change as well, amongst others, and the obesity strategy as well that the government launched. But some of the key documents highlighted here, do have a look at them, particularly towards an active nation, which is Sport England's document, Uniting the Movement, which is Sport England's 10-year vision and strategy around physical activity. Physical activity for children and young people, which is our NICE guidance. Physical activity brief advice for adults in primary care. And the WHO physical activity strategy is also probably worth having a read of. So if you are interested in this space, there's so many policies that connect into healthcare and NHS space, so do take the time to read it. And if you are interested, do reach out and we can always chat about some of these policies further as well. Finally, there are a range of other things to signpost you to. So there is the We Are Undefeatables campaign, which is represented by 15 UK health charities. So that's the Richmond Group charities. There's the Moving Healthcare Professionals we've already talked about. There's the This Girl Can campaign and all the other ones you see highlighted here. So again, do have a look at them online and see how you might fit into them or how you can work with them. In terms of final resourcing, again, worth having a look, particularly at Walking for Health and active partnerships if you're unfamiliar with those. Parkrun works with the Royal College of GPs now to run parkrun practices. So again, some really interesting collaborations trying to really promote physical activity. There's Pool Finder, there's a Royal College of GPs active charter. All of these things are worth having a look at for more information. I hope you found this a really useful starter talking about the NHS long-term plan and the NHS workforce plan. And while these things are highly political, are constantly evolving and changing, I hope they give you some insight into what's going on, the priorities. And I think for us in the fitness industry space, this real push on prevention being key, of which physical inactivity is a key part of that, but also other healthcare health behaviours, which we are really well placed to provide advice on and support on. So I hope you see the opportunities that I think are starting to unfold from these videos, and happy to connect and discuss with you further. Thanks very much for listening.